I'm trying to contain my excitement because I've been wanting to talk about this for a very long time, and now today is finally the day. Lock in. Class is in session. On today's episode of Make It Make Sense Cardiology Edition, I am going to teach you about the power of diuretics. As always, the goal of these posts is to educate and edify the student nursing demographic and the new graduate nursing demographic, so medical terminology will be used. I will keep it as simple as possible, but I need to be professional and informative to my target audience so that they too can learn how to communicate with their interdisciplinary team. Okay, thank you. That said, let's jump in. So diuretics and diuretic management is the staple of heart failure management, because with heart failure, patients are in volume overloaded states. That means that they are retaining entirely too much fluid, and it becomes symptomatic. They start having symptoms from it: shortness of breath, chest discomfort, orthopnea, things like that, leg swelling. So to help our patients feel better, relieve them of this extra fluid volume burden, and take the workload off of the heart, we implement diuretics. Now, what makes the diuretics different is two things. One, their site of action, where they actually do their work in the kidney. And then two, the pharmacodynamic effect. Let's start off with the least potent of the diuretics, which is your thiazide diuretics. Now, these are your hydrochlorothiazide and your chlorthalidone diuretics. Those are examples. The thiazide diuretics place of business, if you will, in the kidneys is in the distal tubules. Now, it's in the distal tubules that sodium reabsorption in the kidney only happens at about a 5% capacity. So, and this is how diuretic or thiazide diuretics work. They actually block the reabsorption of sodium. Now, because they work in the distal tubules of the kidneys, where again, only about 5% of that kidney or that sodium reabsorption takes place, this is why the thiazide diuretics come with a very mild effect. Doesn't mean that they're ineffective, just means that it's a mild diuretic effect. So these types of diuretics are great to treat patients who have high blood pressure, who are not overly fluid volume overloaded. You're trying to prevent the fluid from accumulating to keep the blood pressure down. So this is where thiazide diuretics will come into play. Got it? Moving up the scale, you've got loop diuretics. These are the ones that nurses who work in the hospital setting are most familiar with. Your loop diuretics are your furosemide, your torsemide, your bumetanide, or trade names are Lasix, metolazone, and Bumex. Now, these diuretics, their place of action or place of service in the kidney is actually in the ascending loop of Henle. Not going to go into a big old pathophysiology lesson. Just know that that's their place of business. Now, just like the thiazide diuretics, the loop diuretics block the reabsorption of sodium into the kidney. At this place, at their site of business, that ascending loop of Henle, this happens at a 25% capacity compared to the 5% of the thiazide diuretics. This is why loop diuretics pack a punch when you give them, especially if you give them through the IV. So these diuretics are best used for patients who are overtly volume overloaded. You can see the swelling, the feet swelling, ankle swelling, face swelling, hand swelling, abdominal swelling, and you'll even see some jugular venous distension. Like, you can see the fluid retention on them. Give them loop diuretics without question. Now, bear in mind, and I would be remiss if I did not say this early on, before you give any patient, especially in the hospital setting, before you give any patient any form of diuretic, nurses, please check your labs, look at your metabolic profile, look to see what the patient's kidney functions are, from the creatinine to the GFR, the BUN, and for God's sake, look at your electrolytes. Because if your kidney functions don't look like they are improving, with each diuretic dose or with each passing day, you may want to communicate that over to the prescribing provider so that we can make adjustments accordingly. And it's not to say that we're not looking at it. We are. But when lab results come through, chances are you guys are going to see them before we do. What we do in the inpatient setting is a checks and balances system. So we need you just like you need us. Let's work together. We are an interdisciplinary unit. Okay, moving forward. So we've talked about thiazide diuretics. We've talked about loop diuretics. Now here come the heavy hitters. Now you have mineral corticoid antagonists, or MRAs. This is your spironolactone. Now, spironolactone tablet form is given obviously for diuretic management, but again, it works in a different place in the kidney, or it has a different pharmacodynamic effect. Spironolactone works with the RAS system, the renin aldosterone angiotensin system. In that, spironolactone, or aldactone is its brand name, but nonetheless, spironolactone will actually block the aldosterone receptors in the kidney. What that does is that when the aldosterone tries to bind to its receptor or a respective receptor, spironolactone says, excuse me, I'm sitting here today. When that blockage of that receptor activity happens, then that actually tells the kidney to loose or let go of sodium and water into circulation. In a previous post, and you can look at it yourself, I talked about how aldosterone and sodium don't like each other. They don't like staying in the same spaces. So where you find aldosterone, you are not going to find sodium, and vice versa. So spironolactone, mineral corticoid antagonist, blocks the aldosterone receptors, tells sodium, you got the boot. You got to get out of here and take your friend water with you. And then that gets excreted through urine, thus bringing blood pressure down and offloading extra fluid out of the body. Next diuretic on the docket, you've got acetazolamide. This is a cool one. Acetazolamide, it's a strange diuretic, but acetazolamide will actually block carbonic anhydrase enzymes in the kidney. And I'm definitely not going into the patho about that because it's a very convoluted system. But the take-home point is that when you see acetazolamide or Diamox come into the patient's medication arsenal, look at your labs, and I guarantee you are going to see an elevation in serum bicarb level. That's your CO2 level. Because once that carbonic anhydrase enzyme is blocked in the kidney, that causes not only fluid loss or water loss through the urine, but it's also going to cause the kidneys to let go of potassium and sodium and bicarbonate. What's the significance? When you let go of, or not when you let go of, but if the body starts to retain bicarb, this is again your serum CO2. If the body begins to retain bicarb, bad things happen. Bad things happen. That is called metabolic alkalosis. If metabolic alkalosis is not corrected in a reasonable amount of time, you are going to have detrimental effects. You're going to end up with cardiac arrhythmias. You're going to end up with renal failure. You can end up with respiratory distress, and you can even end up with central nervous system problems like seizures and whatnot. So we don't like that. Acetazolamide is a big one, a heavy hitter. They are really trying to offload fluid in addition to that bicarb. So when you see that in the medication arsenal, take a peek at your labs and, make everything like connect the dots. You can do that. And then finally, this silver bullet here. Finally, there is a medicine called tolvaptan that is only given in the hospital system because you have got to monitor water, or not just water, but you've got to monitor the diuretic effect in addition to the sodium in the bloodstream. Now, the other medicines that we talked about, the thiazides, the loops, the MRAs, and the acetazolamide, Those are true diuretics. Diuretics. Tolvaptan belongs to another class in and of itself that is called an aquaretic. New word, aquaretic. What does an aquaretic do? An aquaretic helps the body remove free water without touching the electrolytes. That was a big one, wasn't it? I'm giddy. So patients who are in what we call hypervolemic, meaning more volume in circulation than we would like, hypervolemic, hyponatremia, low sodium. So high fluid in circulation, low sodium, hypervolemic, hyponatremia. Those are your candidates for tolvaptan. Provided their liver function is okay, because that's where tolvaptan has its, or that's where it's metabolized. Now, tolvaptan works on the V2 receptors of the kidney. These are the vasopressin receptors of the kidney. So when that happens, when tolvaptan comes into circulation, it goes to that V2 receptor where vasopressin is trying to bind, and it says, excuse me, I'm sitting here today. When tolvaptan blocks vasopressin from binding to its specific receptor, what that does is it tells the kidney, you don't have to hold on to water. Water can go, but its friend sodium stays right here. That's diuretics, or at least a quick glimpse into them. Whew. I've been wanting to tell y'all that for a very long time. So I know it's a lot of information. I know it is. Nursing students and new graduate nurses, please take the time to just rewind this post and go over everything at a slower pace. Write things down so you can see the difference, one versus the other. And again, look at your lab work before you give your patient any due dose of diuretic. Just because a medication is ordered to give doesn't necessarily mean it will be the right thing to do at that moment in time. And if you have any questions whatsoever about administration orders or parameters, contact your provider. We are happy to clarify any questions that you may have. That's it, and that's all. That was a good class today. I'm still giddy about it because I really want to talk about some more, because I haven't even gotten into osmotic diuretics. Another class for another day. Digest what you have all learned today. You know how to reach me in the comments. You know I'm going to be happy to clarify or talk about anything else. Class dismissed. Be blessed.